I think we'll begin with our first speaker, whom I had the opportunity to introduce yesterday, but I will repeat some remarks. But I also have had the pleasure of knowing our next speaker for a long time as a member of ABM. And ABM's been in business for quite a while now. But Dr. Julie Taylor is our first speaker this morning. And she has a very unique job. She works in the Caribbean, and she educates. She's an educator. And if I could find my card, I'd be more detailed. But I have managed to come to the podium with every card but Julie's, but oh, here we go. Do I seem disorganized this morning?
Never.
You know, I got in a cab this morning over at the hotel, and I said, take me to the Pew Institute. He said, the what? And so I gave him the address, and he sped off in the opposite direction. I said, you're going the wrong way. Lady, I know what I'm doing. And next thing I know, I'm on the other side of Washington. So I'm a little frazzled. But anyway, let me tell you just a little bit about Julie. She's the Senior Associate Dean, I want to get her title right, Senior Associate Dean for Academic and Student Affairs. She's at the American University of the Caribbean's School of Medicine. She's a family physician. That means she takes care of everybody. And that's an incredible talent. She did her undergrad at Harvard. She got her medical degree at UMass and did a residency at Brown in Pawtucket, and took a 2-year faculty development fellowship at Brown, and she has a master's degree in epidemiology. So with all of those talents, she's going to tell us what to do next. Julie?
Thank you, Ruth. I don't think I'll ever get tired of being introduced by Ruth. It's a true privilege. So thank you for being here this morning. For those of you who weren't here yesterday, I'm the current president of ABM. That's a 2-year position, and there are lots of leaders from ABM here. So I'm going to ask all the ABM board members, Princess Wave, so to make sure that you meet all of these people. Our management team, you've seen lots of them. And I'm going to start with a story here. When Carla, who needs no introduction here, when she said, you know, would you be willing to put together a talk for the upcoming summit? Which is such an amazing request, because I was here at the first summit with my baby, my littlest baby, who was just 2 months old at the time. So I feel like I've grown up professionally and personally with this particular event. So it really is a privilege to be here. And Carla said, well, you know, could you put together a talk? And I said, sure, I'd be happy to. May is a little bit, you know, crazy. So, and I said, oh, I got to put together those slides for Carla. And I thought, what should I call my talk? And I was thinking about it, and then I said, oh, but wow, I bet Carla already picked my title. And I went to the program, and I said, oh, perfect, she's taking care of this for me. So it's called Medical Education and Leadership in Breastfeeding, and I'm going to give Carla all the credit for the title of this talk. And I think that also gives me an opportunity to illustrate to you. We stand up here and speak and talk about these wonderful things that we get to do, but what's really happening behind the scenes is this incredible leadership from Carla and her team. So I just want to make sure that we acknowledge the work that she's done, not just picking my title, but in terms of organizing really the vast majority of this event. So kudos to Carla. I know, it was worth it though. I have a co-presenter here with me today, a real live medical student, and her name's Esther Bell, and you'll hear from her in a little bit. So you heard from my bio, I'm at Brown University. I actually live in Rhode Island. I just have to go to the Caribbean a lot. And so I've been on the faculty for a long time at Brown in the Department of Family Medicine. I went into family medicine to take care of moms and babies together. I thought the health of each other depended on the opposite. So I wanted to do maternal child health. So I've had the privilege of doing a lot of stuff at the medical school there, both in the Department of Family Medicine, and my most recent position at the medical school was as the director of clinical curriculum for the whole medical school for the 4 years. Then actually, these probably should be in the reverse order. I've been a long-time member of ABM, and one of the things that I love about ABM is its global scope and its multi-specialty membership, and those things are wonderful. And it's actually my engagement with ABM that then led me to be very open-minded when an opportunity to work at AUC School of Medicine, which is based in St. Maarten, came up. And I thought, well, I love international maternal child health. Why don't we do the same thing with international medical education? Why don't we make doctors that are training and practicing all over the world? So in addition to liking to work at places that have three-letter acronyms that begin with A, that seems to be a common theme, I'll set the stage with one other story. And so it's no secret that I just adore medical students, and I love the opportunity to turn just people into doctors. And so I was thinking last night about this time when I was on vacation with my husband and our children, and we're in a hotel room, and there are kids sleeping all over the floor and everything. I mean, it's like Saturday morning or something, and we had run out of towels or coffee or shampoo or something that I had asked somebody to come by and drop off some more. And so it's like 6 o'clock on a Saturday morning. The whole family's sound asleep. We're on vacation. There's a knock on the door, and my husband, who's half asleep as he should have been, says, "Is that a medical student?" Because they seem to pop up everywhere in our lives. They're sort of with us personally and professionally, follow us all over the place. So I thought I'd just share that with you because it kind of encompasses what my punchline here is: how do we engage medical students? How do we engage our future physicians, our future healthcare workers, even more broadly, in breastfeeding medicine? Okay. So we're going to talk about just 3 things this morning. I want to make sure we leave time for questions, leave time to hear from Esther. So to provide a foundational framework for physician education in breastfeeding, so that's sort of my curriculum background, and I can give you a little bit of ideas about that. Really want to focus on considering creatively non-curricular opportunities, and we heard a lot about that already. So I'm trying to tie together some of the things from that we spoke about yesterday, and how can we create physician leaders in breastfeeding medicine. And then we're going to have the privilege of hearing firsthand from a current trainee. Okay, so I added the word all, and I think this was really a recurring theme yesterday. I really want to be very inclusive, that we're thinking about how do we educate all maternal child health providers, not just physicians, but I'm really focusing in this talk about medical students and physicians because that's where I do the bulk of my work. But I think it was said yesterday, and is worth saying again, there's so many different healthcare providers that interface with moms and babies, and we need to think very holistically about the whole system. So I think building well-educated pipelines, some of the programs that take people who are undifferentiated healthcare workers, maybe they're going to become a physician, maybe they'll become a nurse, maybe they'll become, fill in the blank. They're in the process of helping moms and babies. So that comes regardless of your particular career path in healthcare. It comes in the form of didactic curriculum, and that's where you build your knowledge. And it comes in terms of clinical experiences, and that's where you tend to be able to most directly build your skills. And then I truly believe in non-clinical opportunities. It took me a long time, probably to fellowship or into my junior faculty career, to realize that there were other people outside of the field of medicine or even healthcare that had an impact on health. I know that sounds so obvious to a room here, but I have developed a much greater appreciation for all the people that impact the health of individual families, individual people, but whole communities as well. So that's my all-inclusive slide. But I want to really focus, number one, on physician education. So this was the first goal. So my kids are fond of saying I went to 25th grade. and then they count them up, or I go to like 3rd grade and classes and talk about school and timelines, and they all kind of glaze over around 16. So if you think about pre-medical education, these are the terms that we use typically in the United States. There are variations around the world in terms of the pipelines. But undergraduate medical education, that typically is terminology that refers to medical school as opposed to undergraduate, like college. So you'll hear the terms UME, and I think that's just an important distinction, versus GME, graduate medical education. That's once you've become a physician and you're doing your residency training or additional fellowship training to specialize in order to be able to practice. So there are many people these days who are going to medical school, graduating with their MD, and don't have any interest in practicing clinical medicine, but there's so many other ways that they can participate in healthcare. So just keep those distinctions in mind. So here's that 25-year timeline, and just this is the visual version of it. So you go to your undergraduate college and you take 4 years of courses, and there are definitely medical school prerequisites, or even if you didn't, if you were a French major or a Spanish major and you didn't do all that science when you were in college, you can do a post-baccalaureate program to get all those pre-med requirements. Then you go on to general medical education, typically more in the classroom. Thank you. I forgot to take my Zyrtec last night. I'm sorry. Thanks. General medical education, usually in the classroom at AUC. That's the classroom setting is on the campus in St. Maarten. And then you take a big test and you go to 3rd and 4th year medical school. And at AUC, for our students, that means going to one of 30 clinical sites all across the US or the UK. And for various medical schools in the US, it means going to clinical rotations, historically more inpatient based, I think that's important, but increasingly outpatient, because that was another revelation I had during medical school. I was like, what? Only 1% of the patients are actually in the hospital? Where are all the rest of the patients? And the 99% you didn't learn how to take care of during medical school, as we move now more toward outpatient training. And then you pick your specialty and you go on to your residency training. Here it says 2 years. The minimum in the US is 3, 4, 5, 6, 7. So some people go to 31st grade. And then you can, optional to go on and do additional training. So you can see that medical school is really intense and really, really, really rigorous process. Okay, so with respect to breastfeeding, right? So a couple of key points about maternal child health and breastfeeding. You got a couple different strategies for these topics and other topics. You can either call them out and say, now we are going to teach you about breastfeeding. Or you can say, well, actually, breastfeeding is in all these places, right? I mean, that's one of the things we all love about breastfeeding: biology, chemistry, anatomy, physiology, and it should be kind of buried in there, right? But what happens then is sometimes people don't realize, if they did get it, that they were taught anything about breastfeeding or nutrition. So I know in general we say, we're under teaching physicians or medical students about breastfeeding. I think they probably get more than we realize, but it's still not sufficient. But just keep that context in mind. And then here you go to medical school, and again, anatomy, physiology, nutrition. Many of you have heard me say, I was actually really looking forward to nutrition during medical school, my 2nd year of medical school. And I remember the whole day, it was about total parental nutrition. And I was like, when are they going to tell us about all that other stuff about health and nutrition and vitamins? I don't know. So it was taught by the surgeons, and it was about when your gut doesn't work and how do you put together total parental nutrition. And so there's a spectrum there in the education. In our clinical sciences curriculum, this is one of the many magic aspects of ABM, is that we've got folks from OBGYN, pediatrics, family medicine, and then the key there is how do we both vertically, so up and down across the 4 years, and horizontally across anatomy, physiology, nutrition, across OBGYN, family medicine, how do we integrate that curriculum? And if we do integrate it well, sometimes it disappears. Does that make sense? So then you go on, once you've picked your specialty, and here now you've graduated from medical school, and we have, you get minimal, if Haywood Brown gets his way, then there'll be much more training in OB/GYN residency programs, right? But there isn't historically that much in the training programs. Pediatrics gets some, family medicine gets some, and there's really very little in internal medicine, anesthesia, psychiatry. These physicians in these specialties, as well as many others that aren't listed there, take care of pregnant moms, of lactating moms, and need that. That's why we go back to the medical school education, so they'll get that foundational level. Okay. Then you've got some opportunities to say, well, this breastfeeding medicine stuff is fantastic, and how do I get even more expertise in it? And the more you do breastfeeding medicine, you realize that you think that's really specialized, but then that's sort of like the tip of the iceberg in terms of where you could go. And I know I'm preaching to the choir here of becoming, you know, the MRI brain expert versus the advocacy expert versus the, you know, everything in between. And so we've got a couple different options for physician training right now. There are fellowships in breastfeeding medicine. There aren't a ton of them right now. ABM is studying the ones that do exist. Dr. Lawrence has been a pioneer of programs like this, and they're more in development in the US. So that's 1 or 2 years of really focusing in on, and regardless of what your residency training was in becoming a primary breastfeeding medicine specialist. Or you can do a women's health fellowship, and those are typically 1 or 2 years, and you could have a focus in breastfeeding there. Or you can do what I did, which was an academic medicine fellowship, and as part of my epidemiology thesis, I wrote about breastfeeding by doing secondary data set analyses. So there's a huge spectrum that you can work through in terms of gaining additional expertise in breastfeeding medicine. And then if you think about more clinical expertise, we have many physicians who go on to do a CLC course or even become IBCLCs in addition to being MDs, and they feel like they get extra training that they did not receive during the pathway that I just outlined to you. Or within ABM, we have a designation for expertise in breastfeeding, which is the fellowship status. So you'll see FABM on many people who are leaders in ABM. So think about those in terms of expertise. So one of the ways that we have to do this, so those are the training pathways, but within that you have your didactic curriculum and you have your clinical curriculum. And I think this just reinforces some of the topics that have already been covered. On the one hand, we've got the New York Department of Education K through 12 curriculum. I'll tell you about a project in a couple minutes that we did with that. There's a lot of really great information in a K through 12 curriculum that is not taught in medical school. I find that really interesting, that could be a potential resource. At the other end, for the true experts in breastfeeding medicine, ABM offers a 1-day course, typically in conjunction with our annual meeting, of what every physician needs to know about breastfeeding. And that's really targeted towards practicing physician or academic physicians, and is rolled out in conjunction with our annual conference, but also at multiple venues, and is really a product that can be taken on the road now. So just thinking creatively about what are the sources. We don't want people reinventing breastfeeding curricula. They exist. Many of you have written, contributed to them, and how do we then just connect the dots and get the providers to the information? Okay. For the clinical curriculum, I just want to emphasize that moms and babies show up in multiple locations, right? It's not just the postpartum ward, and there's so much going on. I think this just reinforces everything we spoke about yesterday about primary care clinics, about women's decisions to how they're going to feed their children. I always ask medical students who are pre-conception, the vast majority of them, how they're going to feed their children, and they all know already, and their kids are hypothetical. And so the idea of working in primary care to talk about breastfeeding, working in prenatal clinics, and the postnatal visits in the outpatient setting, as well as, of course, inpatient labor and delivery and postpartum. And then family medicine, part of the culture of family medicine involves home visitation. So we have a lot of programs that we do with our residents to see patients in their home setting, which is tremendously informative, especially in the postpartum time. So that's what kind of the broad overview of the physician education and opportunities that I can see available to us to further increase the training. I'm going to switch gears a little bit and talk about some non-curricular opportunities that we've got available. And I'm just going to tell you a few stories. I was right, you got a lot of data yesterday, which is fantastic. And I know that this is the choir in this room. So I am here today to tell you some stories, hopefully to get you thinking creatively about additional non-curricular opportunities for creating future leaders in breastfeeding medicine and just engaging that next generation to really pick up the baton and continue to do the work that Dr. Lawrence referred to. So we're going to go through a couple teaching learning examples, a couple research examples, a couple advocacy examples, and then bring it home to mothers in medicine. I'll turn it over to Esther. Okay. So at Brown, this is at Alpert Medical School, students decided that they wanted to start taking care of moms and babies before they got to their third year of medical school. They wanted to dabble. They were studying so much. They needed that inspiration. They wanted to dabble in continuity of care. And so for about a decade now, I've run an elective called the Medical Students Outreach to Mothers to Be. And it has a didactic component. It has a classroom series. And then each medical student is paired with a patient and follows them through their prenatal course, in the family medicine residency. So ideally they attend the delivery and then continue on to work with the family postpartum, which is really, or into the pediatric area, which is really nice. The particular point I want to make here is that in the mom's elective, when I look at the didactic curriculum, I always champion to have the breastfeeding session early. Right? I want it early in the course, right after they've been assigned to their patients, because it's during, it's before labor and delivery, it's in that decision-making time, and so that students get empowered with that information about breastfeeding, just general information during their first year of medical school that they can then bring to their patient, and it gets these really nice dialogues going where they can take those hypothetical concepts and then talk about, they're not really functioning as a healthcare provider, they're more as a patient advocate, which is a really important role. And so some really interesting things have come about that. So I would just, my key point there is the timing is important of these connecting the didactics and the clinical experiences. But I wanted to tell you about is first steps. And this is another medical student driven initiative. We use the New York State K through 12 curriculum. We thought, well, this is quite fabulous. And this totally intrepid medical student said, well, I want to go teach in a K through 12 school about breastfeeding. I want to go to the high school and teach them about breastfeeding. And she's an academic psychiatrist now. She's all grown up. And I said, all right, that's awesome. And so we went to one of the schools in Providence and we said, we'd like to come teach the 9th and 10th graders about breastfeeding. And somehow, I'm not sure why, but we convinced them that we could do this. And what I remember most about that day, and I'm dating this project when I tell you the story, what I remember most about this day is just, she's teeny tiny, just very petite woman, and she's going through, very, very smart, reaching out to the students and talking. And they're, it's like 60 9th and 10th graders or something. It was like a very big audience, this daunting project. And so they were like sort of paying attention and kind of being polite. And then she said like one magic phrase. She said, Michael Jordan was breastfed. And it transformed the room. Like all of a sudden they were like, what? He was right, and so they were like, wow, we want to do that, and it was a little moment using that curriculum that really stuck out. So she wrote a paper about it, and she wrote a program for medical students to teach high school students about breastfeeding, and it doesn't necessarily capture that particular Michael Jordan moment, but if anybody's interested, if that seems like something that you want to bring back to your school and community, the references are at the end for that project. Another thing that, I said this before, that there are lots and lots of healthcare providers who work with moms and babies, right? And you think about the positive aspects of interprofessional education and learning to become healthcare providers together and how we work on teams, healthcare is a team sport, you hear all these things different necessarily from when I trained. And you think about, well, how do we collaborate with our lactation counselor colleagues? How do we work with our nurses? And how do we work with our pharmacists? And so here we had a medical student who had this idea. She said, I've been hearing from patients that they're not breastfeeding anymore because the label on their prescription bottle tells them not to. right? I mean, many of us who are clinicians have had that happen. And so she said, I want to like get to the bottom of that. I want to find that out. So I live in Rhode Island. It's tiny, small. And so what she did was she picked one chain of pharmacy, and the lawyers won't let me tell you which chain it was, but so imagine one pharmacy chain in the state of Rhode Island, and she had a 6-week community health elective, and she drove pharmacy to pharmacy around the state of Rhode Island, and she went and talked to whoever the pharmacist was on that day and asked them what they did for breastfeeding moms, like how did they counsel moms, or what did they say to them, what resources did they use, and there were all these details, you know, and what labels did they put on. And it was an area of potential sabotage and, or more positively, an opportunity for increased education to prolong breastfeeding rates, prolong duration. And so we went to publish this, and this is just in Rhode Island, but I thought it was really fascinating that she went out and surveyed everybody, and so she said more than half of the pharmacists never asked women if they were breastfeeding. And there wasn't a lot of comfort in the educational training around lactation. And if you think about how many women in the first year after they have a baby are taking some medication or other, this to me seemed like an incredible opportunity. And I was really impressed that she just got in the trenches of our state, a little state community, and went to help sort that out. And so I think we're doing increasingly better with identifying pharmacy education and collaboration among healthcare providers, of which our pharmacists are on the team. Okay, so just a second example of how a medical student really brought something to light that I think that was important. Another example, I mentioned that I personally went into family medicine to do maternal child health, but I really got hooked on breastfeeding when I started doing secondary data set analyses. And I know that's like, you know, but not everyone loves doing that and, you know, sassing their way through a year of their life. But I use the National Survey of Family Growth, and I don't know if anyone else has ever used that survey, but it's when you start looking at breastfeeding at a population level, you find out some really interesting things. So it's just another way to look at it. Very, very different taking, you know, crunching national data with you know, p-values and all that jazz, versus sitting down with a bunch of women and saying, what was your breastfeeding experience like? What's your parenting experience like? We're doing these focus groups, and particularly, and this is all going to come together, particularly focusing on women in medicine. So if you bring sort of the curriculum and the maternal child health together, where they intersect is around women in medicine, mothers in medicine. And so I just encourage all of us to think creatively and broadly. And again, one of the things I love about breastfeeding is that you can do a study, you know, using a national data set of 2,100 mothers, and you can learn about birth order and who starts breastfeeding, and you can learn that, wow, you know, however you fed your first child, you're more likely to feed your next child, which totally makes intuitive sense, right? But it's changed the way I behave as a clinician in terms of really putting a lot of effort into that first baby and that first time and hoping for success with the first baby. So that's how my clinical practice has evolved from wonky data set stuff. And then this was, the focus groups was another medical student, she's now a family physician, academic family physician, who said, you know, what are we doing for physician mothers in the state of Rhode Island? And she ran a lot of focus groups, and she had a real, again, small, we're like a little county, but to put together a really interesting group of people to document their experiences, and then to translate that into advocacy, and to make sure that we have pumping rooms at all 7 Brown-affiliated hospitals. And that's very much a creative, you know, collaborative effort among physicians in all different specialties across the entire healthcare system. Okay. Then we've got advocacy is another huge arena. We're in the right place to talk about advocacy in terms of workplace and educational settings, or in terms of legislation, and that's the Rhode Island State Capitol, where I've logged some hours trying to get people to listen to me as a physician about breastfeeding, and they absolutely do. So Esther, they will listen to you as a physician, so get out there and tell your voice. Workplace educational settings, we heard a lot about this yesterday. ABM, you know, we pride ourselves on our globality or whatnot, and so we sat down to write a position statement on workplace in the world. that was a challenging project. But I will tell you, there were questions yesterday about, where do I get resources for my employer? And so this is an ABM statement. This is up on the ABM website. You just can find it under protocols and statements. And this was written by several of us who looked at breastfeeding support for mothers in the workplace, and we decided it was educational or employment or education. So we heard about students yesterday as well. And it's like summary statement for the world. And so there's a lot of detail in there. There are a lot of resources. There are a lot that individual employees could take back, or certainly employers can learn from. So depending on what environment you're in, this can be a really useful document, and it's got great summaries of maternity leave practices around the world. So consider that an ABM resource that is available to everyone here. And then this is me dabbling with legislation in the state of Rhode Island, me and many others. We put together 2 bills. So I think writing bills and getting up there and testifying as a physician is a really important thing to do. You can't really do it yourself. I certainly didn't get that training in medical school. But we have a nursing working mothers bill in Rhode Island, and we then went on to do a breastfeeding in public places. And both of these projects involve medical students because it was really important to get them engaged in these experiences as well, and a multidisciplinary team. And sometimes it bothers me that we need a breastfeeding in public places law. I guess if I step back, that kind of bums me out. But I'm also proud that we have one. So, all right. And then to bring it all home here, the professional development, it's really thinking about breastfeeding mothers and then women in medicine, and then you put these together. At Brown, there's a group called Mom Doc Family. And it's really for mothers in medicine in the state of Rhode Island, although it's actually gone fairly national. This is the original advisory committee that I was on. And it's a listserv, it's a peer support group. It's a wonderful model. And then if you look into, bring it even back down to medical student mothers, and here's a website that 2 of my colleagues from Brown and I put together, one who's a residency, so I do medical students, one who's a residency director, one who's a fellowship director, and also one of us does preconception, one of us does OB, and I do the breastfeeding. So we kind of put together a comprehensive resource that I've gotten a lot of referrals about, because there isn't a lot out there for medical student mothers, and we know that more than 50% of medical students right now are women in the United States, and many of them are having children younger. So this is the paper I get contacted about probably the most often, is medical student mothers. I get contacted by vet schools and nursing schools and all sorts of things. So I've been able to do some consultations with other healthcare professional schools. And because I think, not that you have to have diabetes to care for somebody with diabetes, right? Not that you have to have, that's one of the faults of breastfeeding, is that often women physicians become parents and then they learn, or even male physicians become parents and they learn more about breastfeeding than they ever learned during medical school. But how do we support their professional development so that their personal development, so if they have positive experiences, they can then bring that back to their patients. Does that make sense? So, all right. So without further ado, I've gone through some curriculum, classrooms, didactic stuff, and clinical stuff, and I've gone through some other non-curriculum. So I brought with me a real live medical student in the form of Esther Bell, and I'm going to turn the podium over to her to tell her story for us. Okay?
Thank you, Dr. Taylor. That was a strange introduction. A real live medical student. We're rare. Good morning. Thank you for allowing me to be here this morning to talk to you. And thank you, Dr. Taylor, for inviting me to the conference. It's been a wonderful experience. So my name is Esther Bell, and I am a 4th-year medical student at American University of the Caribbean. And just a little bit about me. I was born and raised in Miami, Florida, and I attended the University of Florida. My degree was in health education and behavior, which is very similar to public health. I actually have my master's in the same field. And it's similar to an MPH, except that it's more of an individualized approach to health education versus population-based, the way MPHs are. And so I stayed at UF, and I completed both my bachelor's and master's in health education and behavior. And then I went into the workforce for a little bit. And I worked as the senior health educator for the Florida Department of Health in Miami-Dade County. I was with the Department of Epidemiology and Disease Control and Immunization Services. And so I was working for a while, but the call for medicine was still there. I was still drawn to it, and that's when I started my journey with AUC. And Dr. Taylor, has asked me to speak a little bit about my experience with breastfeeding education. But I kind of have to tell a little bit about my personal story as well. So my first glimpse at breastfeeding was actually via my family. So I am actually the daughter of 2 immigrants from Nicaragua in Central America, and I grew up hearing about the importance of breastfeeding in these Latin American countries. So I am one of 5 siblings, and I'm the only one born in the United States. So being a first-generation American, being a first-generation college student, and then continuing on for my graduate and now medical education, I heard a lot about how important breastfeeding was, specifically because in countries in Latin America, you don't have access to formula as readily. Many times you don't have access to safe drinking water. And so breastfeeding was really the only safe way, the nutritious way, and honestly the only option for most families in these countries. And so during my undergraduate education, I also learned a little bit more about breastfeeding, especially with my women's health courses, but that was a little bit about myself. So at AUC, as Dr. Taylor has already spoken a little bit about it, we complete our first 2 years of medical education in St. Maarten. That's where we do all of the preclinical curriculum, and we take the usual courses that students take here in the United States as well. So we do pharmacology and anatomy, physiology, the works. And then we're given the opportunity to participate in many other things in the community as well. And so for me, I can talk a little bit about my opportunities at AUC. I was able to participate in something called Project Help, where we were able to go out into the community in St. Maarten and provide healthcare screenings and education as AUC partnered with the Ministry of Health in St. Maarten. I also was able to have the privilege of being elected student government president for 2 semesters. And was able to participate quite heavily, and that's where I met Dr. Taylor actually through meetings through student government. And there's also other ways that we would help in the St. Maarten community, such as beach cleanups or teaching, tutoring local high school students as well. So we had quite a few opportunities to go out into the community in St. Maarten. I personally never had any experience going out into the community in terms of breastfeeding education, but I think that's an area of growth that we could work on at AUC, and I know that things are being discussed to possibly do in the future. And so another opportunity I had was I was part of the Latin Medical Student Association, and we were able to take a medical mission trip to Guatemala. And we were able to give education and screening to residents and children at different schools in Antigua, Guatemala. So that's a few of the opportunities we had extracurricularly. And so now the actual breastfeeding part. So in our medical school curriculum, we take all the courses that most medical students have, and that's really where you get your first introduction to breastfeeding. And so in anatomy, you learn a little bit about the structure of the breast and the way it is formed to be able to produce and store and dispense breast milk to infants. In physiology, you learn how breast milk is formed and the various endocrine processes and the signals to let down breast milk to a suckling infant. In immunology, we learn about the transference of immunoglobulins or antibodies to the baby, that you provide immune function to this newborn infant. And in pathology, we learn about the things that we've all heard about, mastitis, which can be a pathology related to breastfeeding, but we also learn about the protection women have from other diseases because of breastfeeding. And most importantly, with behavioral sciences, we learn about the bonding experience of mother and baby and the psychological benefits you really receive from this experience. And then we transition to clinical sciences. So in my experience, I actually had the privilege of going to the UK, and I was at Epsom General Hospital in Surrey, England for my 3rd year. And that's where I did my OBGYN core clerkship. And it's a little unique because in the UK they have a different approach and a different curriculum when it comes to breastfeeding. They have a more of a holistic approach, and they have a midwifery system. So the midwives are usually those who provide all of the care and support for the mothers throughout the childbirthing process. OBGYNs really only step in when there's any sort of complicated birth or need for a C-section. But midwifery, so the midwives are able to start prenatally speaking to these mothers, giving them education, finding information as to what they plan to do once they have their child. And then once the baby is born, they continue that support. They continue to follow these mothers for quite a bit of time, and they're able to help them with the process of positioning and latching and any other issues that might come about when they're first just learning how to breastfeed, how to have this opportunity to feed your child. And it's really wonderful to see that they have that follow through, and oftentimes they're still your point of reference weeks into being home after being discharged from the hospital. And so, although I personally didn't get an opportunity to be a part of these conversations because they do have midwifery students at Epsom, I at least was able to gather how important it is to educate these women, to speak to them prenatally, to have a plan before the birth of the infant. And so this way we have that opportunity to know what the plan is and try and be a source of support for them throughout. And my 4th year has been a little unique because being that I know I want to be in pediatrics and I want to specialize in neonatology, I did quite a few pediatric electives. And I have had the opportunity to see a lot of breastfeeding mothers, a lot of opportunities to speak to mothers in the outpatient setting as well. So I've done my clinicals at 2 hospitals in New York. I was at Nassau University Medical Center, and that's where I had my NICU elective. And with NICU, we were actually able to encourage mothers to pump breast milk and bring it for their infants in the intensive care unit. And we really encourage all mothers to do that. And it was really an amazing experience to see, especially hearing yesterday all of the benefits that there are to feeding neonates in the intensive care unit with their own mother's breast milk. It's something that I'll take away with me and continue to do and practice. And at NYU Winthrop Hospital, I was part of the ambulatory pediatrics team there, and I was able to participate in health supervision visits. And at every visit, we would always ask about breastfeeding and whether they were still breastfeeding, what can we do to support you during this process. We would try and counsel mothers who perhaps had given up or were saying it just wasn't working and were considering switching to formula feeding. We tried to give them as much support as we could during that process, and encourage them to breastfeed at least the first 6 months, and as long as they would like after that, if mutually desired. But it was something that we did work a lot on trying to counsel mothers. And we would also counsel them on the need to supplement with vitamin D and iron and everything else. But I learned a lot about that interaction with moms. And so that's just a little glimpse into my education and into what I've been able to see of breastfeeding throughout my training. And I'd like to thank you for allowing me to speak to you, and I'll turn it over to Dr. Taylor.
You can see she's on her way, right? Yeah. So we've gone over a foundational framework for curriculum and physician education that can be applied more globally to other healthcare providers. We've talked about some non-curricular opportunities to create physician leaders, and we've heard from an internationally trained medical student. Here are the references here, and I wanted to make sure that we allowed time for questions, but I'll point out to you that this is my little guy Simon, who came to the first summit 9 years ago wearing his AUC t-shirt at Dr. Virginia's clinic. So I just tried to bring it all together there, okay? So we're happy to answer any questions for you guys.
Wow, congratulations. What a story, and thank you both for a great presentation. I have one question, I think for the both of you. I sat on our core curriculum committee about 12 years ago and was intimately involved with our curriculum at UCSD. And literally there was only one sentence in the first 2 years about breast milk, and it was that it could transmit AIDS. And I was outraged. The problem was I wanted to change it, but there were many other problems. Medical school education was changing. The professors were Nobel laureates to be and highly regarded, and there wasn't a lot of cohesion. And so there were other things that needed to be addressed. And so I didn't really take it on then. I can't say I know for sure the curriculum, but I asked the students as they come through in their third year, what did you learn about breast milk and breastfeeding? And whether they were asleep or not there that day, but the answer I still think at my institution is almost nothing. So Esther, I really think you're at a great medical school, but do we have any idea, my question is what kind of breastfeeding, breast milk, lactation education is being taught at medical schools across the country?
I mean, it's still too little, right? It's not enough. There's so many competing demands. Science is expanding exponentially on a daily basis. Their time is not. And so curriculum planning is really challenging, and there are a lot of political issues, and there are a lot of, in academia, there are people who are experts in their field and champions of their health topic, which as well they should be. So there's a lot of moving pieces. I think one of the solutions that we've adopted, I can speak to both Brown and AUC, is to look to national curriculum guidelines, right? So if you look at COMCEP is the organization in pediatrics that does undergraduate medical education and says, here's what a pediatric clerkship should look like. Here are the key things you have to cover. SDFM does family medicine, and there's a core clerkship curriculum, et cetera, through different specialties, the relevant specialties. So that helps a lot, and you can draw on those curricula. Whether they're implemented at the school level, I think is a different issue. But that is certainly one solution, is to go to the national guidelines. I would, for any of you who work in medical education, have you ever heard this simple sentence, assessment drives learning? Yes? So you put it on the test, right? Poor medical students are inundated with everything in the world, right? They're smart. They're going to study for the test because they got to do well on it. So I think that's another strategy that we have collectively, is to look at the USMLE exams, to look at the NBME shelf exams. That I'm throwing around all these names, but the national testing hoops that you go through. And I think that's a place where we can really drive curricular change, because the more we get breastfeeding and maternal child health in general on those examinations and in those questions, the more it then comes back and I find medical student voices to be very powerful. So if they say, we need more of this because it's on the test, I find that to really help leverage as well. So those would be some strategies.
No, I think you're absolutely right. I do think at UCSD, don't get me wrong, they get a lot in the clinical years.
Right.
Hopefully we make it up. But I do think there are some of those psychiatrists to be or surgeons to be that kind of slip through pediatrics or whatever and still come out, anesthesiologists that find that they're lacking because it wasn't in the preclinical years.
Yep. No, that's a great observation.
Can I say something? I only take pictures.
You're disguised as a photographer.
About 15 years ago, I'm Tim Pollock. About 15 years ago, I was asked by our local high school to look at their health curriculum book. And so the first place I looked was in the index to look for breastfeeding, and found 2 references to breastfeeding. This is in the section on childhood nutrition, and it made 2 references, and it, like yours, the only references were, if you have HIV, you can't breastfeed. If you smoke, you can't breastfeed. Nothing positive about it. The rest was all about vegetables and what you should feed your 3-year-old, but nothing about breastfeeding. So it goes way back. And I think I was a little encouraged by Dr. Brown in trying to get OB and residents to be involved. But it starts way back. If they're not taught it in high school, in college, I'm impressed by Michigan State that they have a medical school, but they also have a veterinary school. I believe that we could learn a lot from their veterinary science school. They do. Everybody gets courses in mammary physiology.
You're right.
It's so prevalent in their system, in their veterinary school, that I would dare say that the vets get a lot more stuff on mammary physiology and lactation and physiology than the medical students do. I visited a dairy farm in Napa Valley probably 10 years ago. And I asked the farmer, who had 2 degrees from University of California, Davis, and someplace else. And his bib overhauls was talking to us about lactation and cows and milk and development, and they had a hospital and how they did all that. And I said, what are all those pens out there? He said, those are feeding pens for the newborn calves. And I said, excuse me, I didn't take my allergy pill yet. I says, what are those pens for? And he says, those are for lactation for the cows. And I said, why do you keep them out there? He says, we have to feed them for 3 days. So where'd that come from? What does that mean? He says, if we don't feed them for 3 days, we have a 50% death rate. And this is from a farmer, Bev overalls with 2 degrees, so.
I've learned a lot of medicine from farmers. I would absolutely second that. I think you're absolutely right in terms of interprofessional education or vet colleagues.
Great presentation. I only have a comment. I took my kids to the aquarium in Monterey, California one year, and we walked in and there was a big whale, exhibit of a whale, and it said, how many bottles of milk does a whale eat a day? So I just froze in my steps. And my kids came around me and they said, Mom, calm down. Take a deep breath. I said, why am I upset? Because cows don't take bottles.
Too funny, too funny. Yeah, what we're talking about is culture change too, right? Culture change around curriculum and what's normal, and so thank you for those lovely comments.
Can I ask one quick question? Is there any coordination between dental schools? Because I recently was hearing conflicting guidance, especially on extended breastfeeding from dentists. I don't know much about that education, how medical. Thank you.
I know, yeah, great question. And put in a plug for ABM right now to indirectly answer your question, because I don't know directly the answer to your question, but I do know that ABM has we have opened up our membership to dentists, and we have dentists who are members who are great contributors in those areas that we as physicians need to learn more about as well. So I think it's coming. And Michael, did you want to add to that? I'm not sure if Ruth will let you, but.
All right. This is the last question.
This is the answer to the last question, I think.
Michael Young at Howard University. I do a lecture for
There you
the
go.
dental students on
There you go.
a breastfeeding lecture, and their issue is dental caries, and a lot of their literature has a question about the length of breastfeeding and its contribution to that. But when you really go through the literature, especially worldwide, it does not support it, and that's the message I have to get over to them. It's long-term feeding, but when it's done with human milk, we don't see the caries outbreak. And when you look across the world where dental health is particularly poor, in communities where there aren't dental support, those babies or children who have breastfed exclusively those first 6 months and then continue into the other years have much less caries. So they're always surprised by it. It is an opportunity to talk to them about supporting breastfeeding. And so I think it is an ally. And it's great for ABM to open the door.
Let me just say one more point. I'm sorry. I'm Larry Noble from New York. Just one point about dentists. Both the American Academy of Pediatrics and the American Academy of Pediatric Dentists have really good statements on oral care of infants. And one of the things that they do not say, which you hear all the time, is that breastfed children or infants with teeth, you have to wipe their mouth at night after. Both of those protocols do not have that, so you can take a look at that.
Thank you. See, this is why I bring on the board members with me, because they're really, really smart. So thank you for that. I'll turn it back over to Dr. Lawrence.